Okay, so thanks for inviting me. My name is Amir Abramovich. I'm going to talk about LungVision, intraoperative advanced imaging and navigation system. This is, by the way, what you get if you ask ChatGPT what is LungVision. So I thought I would share it. So this is what I call the PPN diagnostic triangle, and pretty much sums the challenges that we have. We have to know how to get there, which is navigation method. It can be EMN, shape sensing, IR, or your brain. With what we would get there. It can be slim scope, robotic bronchoscopy or catheters, and how to confirm that we are actually there. And this is advanced intraprocedural imaging, which I'm sure that most of you will agree that this is the most important part of this triangle. And what is advanced intraprocedural imaging? First of all, making the fluoroscopy invisible nodal visible. And the solution is augmented fluoroscopy image, a virtual nodal image overlaid on the fluoroscopy image. I put here in first few of our CBCT cases because this is the benchmark that we are all compared to. So this is augmented fluoroscopy, but the problem is CT of body divergence and intraprocedural virtual to real nodal divergence. And this is a problem that the virtual and the real nodal may not overlap. And Michael Pritchett have shown that it can be on average of 14 millimeters. So you can, again, see here an example where the virtual nodal and the real nodal do not overlap, and this is because the atelectasis that formed here because of general anesthesia, which is one of the reasons for this divergence. So the solution is intraprocedural nodal imaging to correct the nodal image for navigation, and most important, to show tool and lesion or TIL imaging for sampling accuracy. So you can see here the virtual nodal, you can see here the nodal with the tool, a slim scope in this case, on the nodal. So augmented fluoroscopy and tool and lesion are two most important parts of intraprocedural advanced imaging. And this can be proved by looking at a lot of studies that have shown yield using different platforms. You see here the old Super D, the Monarch, the Ion, with no intraprocedural imaging. But if you want to pass the 84% benchmark, you will have to combine any platform that you have with intraprocedural advanced imaging. So why do we need a cone beam CT-like system? Because there is a lot of nodules to diagnose. Most of us cannot get any CBCT room or very little at all. Radiation concerns and logistics. If I have to do a cone beam CT case, I have to take a lot of my equipment out of my bronchoscopy suite, and to go into the CBCT room, I would prefer to do it in my own suite. Why LungVision? Because LungVision can give you all the important components that we talked about. Augmented fluoroscopy, tool and lesion capability. It can be used in my own bronch suite with regular C-arm, small footprint, low radiation, and versatility. I can use it with slim scope, with robotic scope, and with a variety of catheters. So how LungVision works? It's actually an artificial intelligence-driven imaging that can take a series of 2D X-ray images from any C-arm in real time and give you all those products that you see here. This is the brain, the AI system, and you will have augmented fluoroscopy with the airway in this case, tool and lesion, and 3D imaging. This was my first test case. It was a very small nodule that I knew that I could get to and see with the tip of the bronchoscope, and this was the ultimate case. This is the augmented fluoroscopy, and you see the tip of my scope right on this nodule. So this was my first case. How does it work? So let's take, for example, this 15 millimeter nodule. I was hoping I will be able to control the speed of the videos, but apparently I can't, but it will be fast. So this is the CT of the patient. Now we take this CT and we feed it into the LungVision system, and then we start our planning. This is the CT that we feed into the system. This is the nodule. We can magnify it. We mark the target. We center it. Everyone who is using cone beam CT can see that this is the same process that you are going when you do a cone beam CT, which is called segmentation. And then you mark the borders of the nodule. This is not during the procedures, okay? This is before. And it takes this is real time, okay? So now you get this nodule, you mark the airway, and then you get also your pathway. There is even a virtual navigation to there. And then, this is the actual bronchoscopy. So, what you saw before, we could have done like a few days before. You have to center the system with the patient. So what you do is you do a spin around the carina. You mark the carina on the CT to feed into the system, and then you mark the carina on the CABT reconstruction of the system, and then the system tells you how to center the nodule in the middle of the C-arm spin. And then you do another spin which takes about 14, 15 seconds. You confirm the lesion. This is your augmented fluoroscopy, exactly like cone beam CT. You can see the lesion, you can do LAO, RAO, you can see that you are still on the lesion. This is the part I wanted to skip. So we navigate to the lesion using a thin scope. This is a sampling. And this is very important. This is a tooling lesion. This is the scope in real time. This is the nodule. And you can see that your tool or your scope is exactly on that nodule. And if you want, you can even have a 3D reconstruction. So this slide is showing you that with LungVision you get the good for both worlds. You have the expensive high radiation systems like fixed and mobile cone beam CT. You have the low quality, low radiation, low price 2D systems, and LungVision gives you full 3D, low radiation, and relatively low price. This is how a sub-centimeter nodule look like. This is the CT, this is the LungVision reconstruction. And this is a subsolid nodule and a GGO nodule. This is the aitoma, which intensifies the nodule. You can clearly see that you see it very good. So how LungVision compared to the gold standard CBCT? I chose these two studies, which is all studies done with the first generation of the system. And those studies compared navigation with LungVision tools to using the LungVision augmented fluoroscopy. And you see in this study that was presented in CHEST 2018, the RIBA's LungVision capability was 90%, and the end of the LungVision catheter and the cone beam CT was 95%. Here too, this is Michael Pritchard's study, And the LungVision augmented fluoroscopy to the actual CBCT location distance was 5.9 millimeters, but the intraprocedural CT2-body diversion was up to 33 millimeters. They actually didn't use here the capability of the system to correct for nodal movement. So what you can do is actually to do another spin and correct the augmented fluoroscopy. But even as it is, it's very impressive. Another thing that this system can do is AI tomo, and this helps us to find very difficult nodules in a very crowded anatomical space. I will run fast forward so I can make the time. So future development of the system is to continue to improve quality of AI tomography and the ability to image dual lesion. You have a wider angle here. You see here that this is the old tomo, this is the new tomo, and this is the axial view of the old and the new tomo. Another development is all those are C-arms that are compatible with LungVision. The highlighted one is the ones that you can use with AI tomo, and the purpose is to highlight all those different C-arms. This is real-world diagnostic yield with LungVision. It was used with Monarch, it was used with Intuitive, and it was used as a standalone. You can see here the yield of the system. I will skip that. In terms of radiation, this is an unpublished data of Wilson Tsai that I present with permission. This is the Cyospin 3D that was used as its own as a 3D system or as a 2D arm with LungVision. And you can see that when it was used as with LungVision, it gave half the radiation per case and fifth the radiation per spin when it was used as a 2D arm with LungVision. And because of this very low radiation, you can even use it in pediatrics. I think this was the first case that LungVision were used in pediatrics. It was a 30-year-old with carcinoid. So we used the system, we used the C-arm, and it was a very low radiation. We didn't hesitate to use it. This is my last slide. So the purpose of LungVision in the future is to actually improve the navigation, improve the bronchial tree reconstruction, and to make the intraprocedural image better, so we will be able to use it with ablation and even in other organs. That's it. Thank you very much.